Hello, my name is Faraz Atak, and these are my teammates Karina Patel, Savika Allure, and Akshay Dawi. Today, we're going to be presenting our project, The Chase to End Cardiac Disparities. One of the most significant disparities that should be addressed is the disparity within ethnic communities and heart health. We believe that we are only as good as our community, which is why as a team, we want to not be complacent, and as our acronym says, chase to end cardiac disparities. This means taking initiatives, which is exactly what we plan on doing in our project. However, before we delve into initiatives, it's important to learn more about heart health and just how prevalent it is. Heart disease is the leading cause of death in America, killing more than 655,000 Americans every year. That means every 1 in 4 people die from heart disease. Coronary heart disease is the most common type of heart disease, killing more than 365,914 people each year. About 18.2 million people who have coronary heart disease are 20 and older, which is 6.7%. And 2 in 10 deaths happen in adults less than 65 years old. So, what is the difference between optimal heart health and poor heart health? When it comes to heart health, it's important to maintain sinus rhythm, which is an up-note P wave and leads 2, 3, and AVF. Even just knowing how your atriums and ventricles are alternately contracting and relaxing to pump blood to your heart are crucial for optimal heart health. Poor heart health can lead to cardiomegaly, which is an abnormal enlargement of the heart. Other signs of poor heart health are bradycardia, a slow heart rate, tachycardia, a fast heart rate, and a common arrhythmia, atrial fibrillation, which is another rapid heart rate. Preventive measures are crucial for optimal heart health. That means looking at your blood pressure and making sure it's less than 120/80 millimeters of mercury. Certain dietary restrictions, such as eating more vegetables and fruits, going by serving size, limit sodium, limit certain fats such as trans fats, things like that. Then make sure you exercise every single day for at least 30 to 60 minutes. Other preventive measures are proper alcohol consumption, which is about 1 drink a day for women and 2 for men. And then of course, no smoking, and try to reduce stress levels as much as possible. All this information is so prevalent, especially today for these different ethnicities because of the different genetic predisposition and other barriers that they face. However, we will delve into more detail about that and more later on. Now I'll pass on to my colleague Karina, who will talk further more about these disparities.
Thank you, Faraz. People of different races, gender, and income status experience multiple barriers when trying to access healthcare. Specifically, Hispanic, African American, and Asian women are at the highest risk of developing heart disease, yet they have the least access to a regular source of medical care. And this is due to the amount of barriers that exist in today's society. One of the biggest barriers that exists today is communication. For many minorities, English is not their first language, so there's a language barrier between their doctor and their patient. And this impacts the patient's ability to form the necessary connection that they need in order to receive the best possible care. As you can see in the graph below right here, of all the cardiologists in the United States, only 2% are African American, only 3.8% are Hispanic, and only 12.7% are Asian, compared to the 82% that are white. The lack of diversity in cardiologists contributes to the problem of unequal care. In addition, there's a gender bias against women. Women are often diagnosed at a later age and stage than men, experience more severe hypertension and diabetes, and also experience longer stays in intensive care units and poor outcomes. In addition, different races are grouped based on shared physical and social qualities. For example, people of similar races tend to live near each other, share certain behavior characteristics, and have similar social exposures. Because of this, certain races are at a higher risk than others for developing heart disease. For example, Asians. Asians have smaller blood vessels and tend to have diets that are high in saturated fats, and this increases their risk of developing coronary artery disease. Now, when talking about low-income areas, the socioeconomic status of Hispanics in the United States is considerably lower than that of non-Hispanic whites. As you can see in the graph below right here, of the people living in low-income areas, 58% are minority and 30% out of the 58% are Hispanic. Another study was conducted and concluded that 56% of Hispanic adults aged 25 and older had a high school diploma compared to 88% of non-Hispanic whites. This correlates with the lack of education in low-income areas. In addition, with the structural and social inequality that already exists, it leads to a lower accessibility in medical care. Because when minorities do try to access the hospital and clinics that are available to them, these places often lack advanced treatment options and lack a high quality of care. All of these limitations have a direct link to the development of heart disease and heart failure. I'll now pass it off to my colleague Savika so she can tell you more about the clinical disparities that exist.
Thank you, Karina. Recent studies have shown that despite the improvements in the overall quality of healthcare, racial and ethnic minorities still experience a lower quality of healthcare. As Karina discussed, they are less likely to receive routine medical care, which causes them to face higher morbidity and mortality rates as compared to non-minorities, which ultimately causes the clinical disparities caused by their genetic predispositions to be overlooked and ignored in cardiac health. Specifically, a clinical disparity that disproportionately affects certain minority groups over the others is hypertension, which is blood pressure over the normal 120/80 millimeters of mercury. As you can see in this graph from 2016, African American adults over the age of 20 were 42.1% likely to have hypertension as compared to only 22.7% of non-Hispanic white counterparts. This is mainly due to the prevalence of undiagnosed and untreated risk factors caused by the low accessibility of healthcare within these communities that puts them at a greater likelihood of experiencing adverse conditions and greater dangers. Specifically for African American groups who face the highest death rate from cardiovascular diseases, fail to recognize that underlying risk factors and health conditions play a major role. African American adults have a brain-type natriuretic peptide that is directly linked with being an independent biomarker for predicting events related to heart failure, stroke, diabetes, and other heart-related events. African Americans having higher BNP levels compared with Hispanics and whites reflects on their highest risk for hypertension and other diseases. Their less likelihood to receive proper medical care just exacerbates these disparities even further. The patterns in racial disparities seen in hypertension can be seen for all other cardiovascular risk factors such as obesity, diabetes, high cholesterol, sleep apnea, sudden cardiac arrest, and ultimately sudden cardiac death. By recognizing and advocating for these disparities, we can move forward towards reaching equality in healthcare for all racial and ethnic minorities, a process that Akshay will now discuss further.
Thank you, Satvika. As you can see, there are a multitude of factors that are contributing to this ever-growing and ever-evolving issue that is racial disparities in cardiac health. In a similar fashion, we need a multidisciplined approach that focuses on communities as a whole when working towards finding a solution. As such, let's dive deeper into the intricacies of each of these different approaches. One method that has seen past success is known as lifestyle-based intervention, or LBI. This method focuses on altering certain aspects of a person's lifestyle, whether that be their exercise regimen, their stress levels, or their diet. For example, in an African American study group, a Mediterranean diet exemplified by lean meats such as chicken and fish, and along with nuts and leafy vegetables, marked a 73% reduction in cardiac events and a 70% reduction in mortality overall, making it the only known diet to have an effect on either of these two statistics. Furthermore, in another African American study group, stress reduction therapy marked a 10 millimeter of mercury decrease in blood pressure from stage 1 hypertension to a mere elevated level. However, lifestyle-based intervention is not the only method that has seen past success. Community-based support groups have also shown to reduce the prevalence of these risk factors in minority groups. For example, in a study that reviewed the efficacy of community-based support groups, it was shown that patients in these support groups were 2 times more likely than their traditional counterparts to reach healthy levels for LDL cholesterol, which is less than 100 milligrams per deciliter, and blood pressure, which is less than 120/80 millimeters per mercury, as my colleague Faraz mentioned. Other types of interventions that have seen past success include support groups, which seek to bridge the language barrier in these minority groups, medical interventions, and youth programs such as SCARF itself, which seek to ingrain an awareness of these issues in the next generation in the hope that they may carry it into their adulthood, where they're at the most risk for these cardiac events. Now, you may be wondering what other measures can be taken outside of these communal interventions to reduce the prevalence of these risk factors among our minority communities. Well, some ideas that may be entertained in the future include a reduction of social bias in the medical field through certain psychological techniques, increased involvement of minorities in cardiac research, and an increase of healthcare providers in underserved and rural locales. As such, our solution aims to integrate these issues and strategies and consolidate them into a singular goal. We decided that the problem at hand was twofold: a low level of awareness and education in these minority groups, which are at the most risk, and a mental and emotional disconnect between these same groups and the medical community. We decided we wanted to combine these two issues in a synergistic fashion by talking with medical professionals who are part of these minor groups and gaining insight as to what these problems really are, how they're perpetuated, and what the root cause of each problem is. Furthermore, We wanted to share our understanding of these problems with the community, so we decided to create an Instagram page, as we believe it is the most effective way to transfer information from one party to another, and we hope to continue this initiative along past this symposium, as we believe we are the link between our community and the long-standing issue that is racial disparities in cardiac health. That was 5 seconds. In those 5 seconds, another 6 Americans have passed away from cardiac arrest. We want to leave you all with this thought, so thank you for this time, and we hope you join the chase.